Hi, so I'm Aera. I'm a licensed massage therapist in the city of Seattle. Some of you in my group have expressed interest in knowing what intraoral is, so I'm here to make a quick video about that. First of all, I just want to show off my handy dandy notebook. This notebook is not complete. I've got a couple more things to gather in here, but as you can see at the top, we have intraoral. At another time, if there is interest, I'll talk about how I assess and treat for thoracic outlet syndrome, but I can't diagnose it. Okay, so let's move on to the handouts. So all of these classes that are in the notebook have been taught by Michael Hamm, who is an individual also in the Seattle area who teaches this stuff. And I've kind of become obsessed with his work, so here we are. So when I first graduated at the Cortiva Institute, it was 2016. And the first thing that I got was an intraoral certification. I was interested in it because it was different, and also because you put gloves on in order to massage inside the mouth. And I thought that was really unique. I haven't really heard of that as being a massage thing. Usually when we think of massage, we think of spa and relaxation. So the first class that we took was a neurofascial approach to headaches. As you can see, this is Mike Hamm's work. He put together all of these handouts, and then I drew on them. So the first thing that I want to show you is some of the cranial anatomy and the upper cervical spine, or upper neck. Kind of this area back here. I'm not sure if you can really see it, but here's a diagram. So headaches can be cervicogenic, and which means that they come from the neck. And you can see these different parts here. Here is the inferior nuchal line. That's the bottom ridge, the very base of the skull. Then we have our nuchal ligament, which runs right here. It's a very thick ligament. It's also a form of fascia. And then our blood vessels. And then these things right here, these little patches of muscle there, are your occipitals. So you can see that there's a lot of anatomy here. In order to do intraoral, I needed to learn this because what happens inside the mouth can be affected by these muscles and the tension. I find that a lot of people, after I've done a fair bit of work on them, will actually loosen up in the neck into the upper traps. So the top of the shoulder, where a lot of people say they feel knotted. So the next thing I want to show you is this bottom diagram, which really kind of shows the placement of the vertebra. In particular, C1 and C2, so the atlantoaxial joint, which is in here. You could see these little muscles here, and the illustration shows some of them cut away. They all attach to C1 and C2, and they allow you to do this with your head. Really fine movements. These muscles are also attached to your eyes, so they're connected to your eyes. One of the tricks that I like to play with one of my clients is I rest my fingers into the base of their skull. I really wish I had a fancy skull model like Mike Hamm does, but that's okay. And I have the client move their eyes around, and they can feel it. They can feel like a little bit of a stretch. So that's interesting. So there's a lot of connections between the base of the skull and the jaw and the eyes. And why does this all matter? Because the trigeminal nerve comes out, and it encases the face. So you've got things like the facial nerve. The trigeminal nerve, also known as facial nerve 5, is a nerve that innervates the jaw. When people have TMJ, they can often have issues with this nerve at some fundamental level. And so that's what I'm looking at as well when I'm doing intraoral work. The next thing that I want to show you before I go into the demonstration is the second handout, which specifically this one that we got talks about jaw pain. And so if we look at this diagram closely, you can see there's the temples up here, the temporal, the artery that feeds that tissue, and then you can see all these branches of the nerves. Look at that. We've got it going into the jaw, we have it perforating out by the nose, here, and then we've got, you know, other innervations as well. And so could look at these muscles and the relationship here. It's not just intraoral work that I do, that's part of it, but I also assess and treat stuff in the front of the neck, also known as the anterior neck. When we have issues swallowing or chewing, or maybe we have spasms, those muscles that attach to this bone here, the hyoid bone, this little tiny bone right here, they can be taut. And so when you're dealing with potential nerve-related issues or structural dysfunction of the jaw, like with TMJ, or maybe you are an individual who needs jaw adjustments from a chiropractor, something's out of place, or you experience a lot of muscular tension, you carry on just a lot of stress up here, it's very beneficial to get through here. So just going to show you the inside of the mouth real quick. Thankfully these aren't cadaver shots. That'd be pretty gross, wouldn't it? Someday you'll see them. So this is the bottom of the jaw. So we're looking up here. It's a cutaway and we're looking straight up here. So here we have the division of your sinus cavities, and then here attaching on the inside of the mouth down to the jaw is a pterygoid. It's the muscle that lets you do this. And in my opinion, not only is it beneficial to get inside the mouth for bigger chewing muscles like the masseter and the buccinator, it's also very important to get inside and get into the way back so that we can make contact with the attachments of the pterygoids. We can also do that underneath the jaw through here. It's a sideways image of the jaw here, and you can see the nerve, which is the yellow line, and how it travels down to here. So I've had some major dysfunction in my jaw as a result of upper cervical injury, and as a byproduct of that, I did experience some numbness and what we call loss of proprioception of my teeth. So I felt like I just didn't have teeth. I felt like I had holes in my mouth, but if I put my finger and I felt with the nerve endings of my fingertips, I knew I had teeth. But the sense, the feeling that was coming from the tooth trying to travel up through and give the signals to the brain from that location was telling me I did not have teeth. So these nerves are really important. Okay, so to go into the demonstration now, in order to become certified for intraoral in the state of Washington, I had to complete these 2 classes, and I had to pay a fee and register with the state of Washington to get this. It's the second certification that I'm allowed to get because I'm a healthcare professional whose scope of practice allows this kind of work. So I'm just going to grab a couple of gloves. And generally what I like to do is I like to do a lot of outer work first. warming up the tissues, doing a little myofascial, neurofascial. But for the sake of just getting the basics down, I'll show you a couple of the main things that I would usually do inside of the mouth that I can also teach somebody to do to themselves. When I have people come in and they're suffering from migraines or headaches, or their jaw clicks or even dislocates if they yawn too wide, I like to teach them these things. So the first move is sort of a pincer grip, but since I'm doing it to myself, it's going to look differently. Typically what will happen is, if you can imagine this being my cheek, my fingers go inside the mouth and then I grab like that. So my thumb is on the outside of the cheek. But because I'm doing this to myself, it's going to be the opposite. The same thing follows, or not the same thing follows. Something else too is we use my pinky finger to get inside the mouth for the pterygoids, and that will be the same on myself. So what I like to have my patients do is open and close their mouth a few times so I can see where the dysfunction is. Okay, so when I do that, I notice that I have some clicking and I hear it coming from here and back here. So for me, with my experience, that tells me that I should definitely investigate the left pterygoid and the right masseter, buccinator. But that may not be true, so I'm gonna, if I were my own patient, I would address everything and do like my whole intraoral routine and just kind of explore inside the mouth. The other thing I have them do is I have them wiggle their jaw from side to side, because that does check specifically pterygoids. If the jaw is dragging, like if they're like this, then that tells me that there's tension or there's an imbalance in how those muscles are firing. I feel like I've got really good stretch when I go this way, but when I go this way, there's resistance here. Okay, so then we're going to do the first move, and I'm going to come in at this cheek because that's easier on myself. On the patient, I may do it same side or opposite side depending on what the horoscope is that day. No, I'm kidding. Okay. So, our thumb. Sorry, I reach far back. I'm reaching far back because I'm trying to get to the attachments of those muscles. And then my outer two fingers are going to press into the muscle bellies. Like this. Yeah, still getting used to the camera. So there's this grabbing motion that happens. Sorry, there's this grabbing motion that happens. Now, I don't have my patients talk when my fingers are in their mouth. I have a nonverbal communication that way consent is honored. I am tender. This can be tender for a lot of people. And the reason why I'm showing this to you is I want to sort of demystify what this is. There's a fair number of patients I have encountered where I've seen the benefit of doing this work, and they've been really afraid. To them, it's like, whoa, that's too much like going to the dentist. Don't put your fingers in my mouth. Or they're like, oh, I'm not really comfortable with it, but you can do outside work. And in some cases, outside work is all you might need in that moment to make you feel better or help you get better range of motion. But it may not be complete. And I like to do very thorough and complete work. For somebody who's as sensitive as I am, who has some nerve dysfunction from an injury 2 years ago, I have a lot of pain points. So when I'm grabbing it, I'm feeling pain coming up into the side of my eye. And that's not all that uncommon. It doesn't mean that I'm hurting myself doing this. It just means that there's irritation. And if I can find the source of the irritation and help soothe that, then the overall function of my jaw will get better. So moving on to finding the pterygoid inside the mouth. What happens is I inform my client that I'm going to glide my pinky finger over the top of their molars, the bottom row, and then I'm going to kind of come up like this to put some slack on the tissue there. And sometimes I might grind the pinky finger a little bit on the muscle depending on how accessible it is. But if I just want to make contact with that area, as the nerve is accessible through there, it doesn't mean I'm able to really touch the nerve. But what it means is that when I put slack on the tissue there, I can give that nerve a moment to breathe and say, oh, okay. So it's just kind of a way to retrain the sense there. If I'm not sure if I'm on it, I might have them wiggle their jaw from side to side, and I may feel something kind of like move, and then that tells me that I'm in the right area. Yeah. That's really hard to do for me on myself for some reason. The other thing too is using the pinky finger, we can come underneath the tongue. So I'll have them put their tongue to the roof of their mouth or move it to the side while I do this. And when I'm doing that, I'm contacting these muscles that attach to that bone. So you can think of them as kind of like slices through here. And so, like that. The other thing that I might like to do is put some traction on the hard palate, which I'll do with my thumbs. So that's kind of the basic rundown of intraoral. There's quite a couple different ways to approach it, and that's just the intraoral component. When I do intraoral, I'm also, looking at what's underneath the jaw and in the anterior neck, as well as getting these intrinsic muscles at the occiput and helping to release the tension and pressure that one might feel in the upper part of their neck. I think it's a very valuable tool that we have as manual therapists. I think that for massage therapists who might be watching this, I think it's worth adding to your repertoire if you want to go in a clinical direction or if you want to work with people who are headache or migraine sufferers. I feel like I've had a lot of good laughs with my clients in doing this, and I have had a fair number of clients return to me repeatedly for this work because it makes a difference for them in their situation. Okay, so I know that I didn't get too much into detail with anatomy or function. I showed you a bunch of pictures. Please feel free to ask me questions, either in the comments or in the group. I'd be happy to answer them. And if there's something more that you want a video on, please by all means let me know. Subscribe to my channel if you haven't already, and just keep your eyes open for news and updates. Thanks.